I'll be covering the applications of ctDNA and the new findings that were presented last year in some of the landmark Phase III trials looking into ctDNA to use in molecular progression as a biomarker for molecular progression, as well as some of the ongoing trials looking into escalating therapy based on this biomarker, also in the targeted therapy setting, not only in the immunotherapy setting, because we do have some open studies, and also briefly talk about the potential of implementing this in a population that undergoes surgery for their early stage lung cancer and the barriers that have prevented us from deploying this to clinic at this time. For many years, we had small studies looking into the prognostic value of ctDNA, and we know it's a prognostic biomarker. So last year at ASCO, Natalie Vogts and myself, we presented data from 2 Phase III studies. Natalie's group presented data on IMpower131, where patients received the Cemiplimab monotherapy for non-small cell lung cancer with high PD-L1 expression, so over 50% of PD-L1 expression. And what her group found is that when you look at ctDNA clearance at 3 weeks and 9 weeks, you can clearly see a difference in outcomes for patients that have cleared the ctDNA from cycle 1 to that time point and the ones that didn't, suggesting that you probably could use that time point to then change therapy before you even see radiographic progression, right? And they also did a combined score analysis with imaging that made the biomarker even more powerful. My study, we looked at samples from IMpower131 that was for patients with squamous cell carcinoma of the lung treated with carboplatin, nab-paclitaxel, and atezolizumab. And what we saw is that the dynamics of ctDNA, they do matter for risk stratification, and the time point that we found was the best for you to potentially make a decision of changing therapy would be after 3 cycles. And even if you want to look into a more cost-effective strategy where you just look at one single time point and you don't take into consideration the dynamics of changes and you just say it's going to be positive versus negative at cycle 4, day 1, then the biomarker remained very prognostic, independent of other clinical factors, including pathological features such as PD-L1 expression. So showing this is an independent biomarker, right? So Dr. Anagnosou's group at Hopkins, they started a study where they are gonna evaluate ctDNA clearance after 2 cycles of pembrolizumab for patients that have a high PD-L1 expression, and the ones that have the ctDNA still detectable, they have not cleared, they're gonna randomize to addition of chemo versus continuing pembrolizumab alone, because the hypothesis is that the patients that have not cleared, they have a high risk for disease progression and shorter survival. So you should intervene earlier before you see the radiographic evidence of disease progression. So that's one of the open trials in the immunotherapy space.